Hello, I'm Manvi Smith, a clinical psychologist with Providence in Washington. As part of Providence's system-wide Zero Suicide Initiative, today we'll be introducing the suicide screening, risk assessment, and safety planning protocol. The goal of this protocol is to provide care for patients that utilizes evidence-based interventions and tools, meets best practice guidelines, as well as the Joint Commission standards. It also mitigates risks for both patient and providers while enhancing patient safety. The goal is to better help our patients. Addressing suicide with patients can be anxiety-provoking for providers and caregivers. And by standardizing this process, we are also giving our providers and caregivers a simple 3-step evidence-based process. This is a simple 3-step process. The first step is to identify risk. And then we move to risk assessment, and then is the safety planning intervention. We understand that there's a great deal of variation in workflows, and processes will be different in each care setting, but it is important to understand that the steps in caring for our patients remain consistent, whether it's in the primary care setting, the emergency department, or inpatient settings. Our workflow is always to help identify, assess, and provide an intervention and treatment. It is also our recommendation that each setting plan and coordinate the activities with their caregivers and management teams to deploy these recommendations and tools and have it adapted to their specific setting. It starts with identifying risk. This could be a population-based screener, such as the PHQ-9, which is used often in primary care. The goal is essentially to identify risk. Once the risk is identified, risk assessment is undertaken with the Columbia Suicide Severity Rating Scale. And the intervention is safety planning. The PHQ-9, or the Patient Health Questionnaire, is a self-administered questionnaire that can also be administered in person, on the telephone, or virtually. It's used for diagnostic purposes to quantify symptoms of depression. It's used to assess the severity of symptoms, and each item on the PHQ-9 is scored from 0 to 3, with overall severity of scores from 0 to 27. The PHQ-9 is used in primary care as a guide for prescribing, or also to measure recovery and response to treatment. When we look specifically at item number 9, thoughts that you'd be better off dead or of hurting yourself in some way on the PHQ-9. It is scored like all other items from 0 to 3. And when we look at this statement, thoughts that you'd be better off dead or of hurting yourself in some way, it is a broad statement, and any non-zero response leads to step 2. Step 2 is risk assessment. This is done with the Columbia Suicide Severity Rating Scale. This scale is designed to quantify the severity of suicidal ideation and behavior. So a question is, who can administer the Columbia Suicide Severity Rating Scale? Anyone can administer it. And when should this be administered? When a patient endorses question 9 on the PHQ-9 or a population-specific tool that identifies risk. Any non-zero answer would lead to the administration of the Columbia Suicide Severity Rating Scale. And the wonderful thing about it is that it can be administered on the phone, virtually, or in person. The Columbia Suicide Severity Rating Scale supports suicide risk assessment through a series of plain language, simple questions that anyone can ask. It is designed to quantify the severity of suicidal ideation and behavior. And it is the only screening tool that assesses the full range of evidence-based suicidality and provides criteria for what to do next. The answers help users identify whether someone is at risk for suicide, assess the severity and immediacy of that risk, and gauge the level of support that that person needs. So once again, who can administer the Columbia Suicide Severity Rating Scale? Anyone can administer it. When we look at the Columbia in EPIC, there are 6 questions that can be asked in just a few minutes with no mental health training required to ask them. There are first two questions, and then for positive response, it will drop down. The Columbia is also a wonderful tool because it increases efficiency by allowing resources to be directed where they are needed the most. It reduces unnecessary referrals and interventions by more accurately identifying who needs help and the level of support a person needs. The third step, the intervention, is safety planning. Why use safety planning instead of no-harm contracts? No-harm contracts involve a commitment to what a patient will not do in crisis. It is not recommended for patient care because there is no evidence that they work. It's not a legally enforceable contract, and what it does do is show that a provider believed that the patient posed some level of risk to themselves and simply took their word that they would be fine. No-harm contracts are clinically ineffective as an intervention and also are a risk and liability issue. Safety planning, on the other hand, focuses on committing to what a patient will do in crisis or to manage a crisis safely. This is an evidence-based intervention that simply saves lives. Thank you so much for your time today. We hope that you find this three-step process an effective way for managing what could be very stressful in your clinical practice.